My name is Lowell Kadnick. Welcome to Veins and Lymphatic University Grand Rounds, featuring important topics through case discussions. Grand Rounds will occur every Wednesday from 12 p.m. to 12:30 p.m. You can tune into Zoom or YouTube. Our featured speaker today is Javier Calatayud from Argentina, who will talk about a new technique from treating certain types of vein issues known as a sausage technique. This will be followed by our discussants, Shoa Padira from Italy, Tobias Hirsch from Germany, and Emery Bahari from Hungary. To our guests, please use the chat box to post questions. Javier, the floor is yours, but Victor's going to play your recording. Thank you, Victor.
Sausage form sclerotherapy concept.
Everybody's watching the screen?
Leaks. Very
Yes.
grateful for patient to share sausage technique, especially to Dr. Victor and Dr. Lowell. Type look like a sausage with transitory rubber ligations. First, it's a practical presentation of sausage technique. Sharing my daily practice, sharing experience can change or improve this technique. Concept: sclerotherapy between two rubber transitory ligation with trendelenburg position, dense form, and ultrasound guide. Personal tourniquet: call me with a plastic tube and a rubber band and a clamp, very similar to cardiovascular surgery, or may use simple rubber tube or gloves. Position is slightly trendelenburg. Trendelenburg and rubber ligations reduce 30%, about 30% vein diameter. Other example, using tourniquet for leg treatment, we tied number one transitory ligation on the ankle, and the second one, number two, on knee. For tie, we untie number one or ankle transitory ligation and tie on the ground. For infrapatellar veins, for suprapatellar veins, for back position. About form, dense form, ratio 1:8, glass searing, and polydocanol 1 to 3% or more. Searing, I use a 3 millimeters and a 10 millimeters searing, joining with the nasogastric, a piece of nasogastric tube. Why a tube? Because you can flex the tube and improve turbulence and a better form. An example of form and making a snowman. Other example of form or very dense form. Glass is better than plastic. How many passes for good form? I think it's better to listen the passes between searings, and when no sound, the form is okay and is dense. Remember, only device like scleroform, variation, Dr. Ulloa form machine give to us a precision in form quality. Traditional form are artisanal, and we only guide by aspect sound etc. Tiny needles may use for dense form. I prefer a 21 needle or a 25 needle. How works? Less form runoff, less form injection volume, more contact form endothelium, and less vein blood inside the vein. Amount or concentration is very important. The personal clinical experience. Remember, sclerotherapy is an artisanal technique, and the sclerotherapy is have to find personal results. Ever injection and control. Between the limit of that and dense form, we describe a zinc is the chessboard of zinc. After injection, eccentrical compression, test of cotton and dentist cotton. What happened releasing rubber ligation? In video, now massive migration to deep veins, releasing the tourniquet. Results: a 40 millimeter venous aneurysm, a reduction of diameter 1 month later to 6 years. More results. Remember, injection is important, but thrombectomy are important too, very important for results. Conclusion: no DVT, less thrombophlebitis, less sclerosis or very short sclerosis, less pigment. Not for newcomers. Thank you.
Thank you very much, Javier. That was clear. I'm going to take the liberty of starting with questions. The questions were, and I think you answered it on the chat box, was how much do we see in the deep system of the foam? So in a deep system, Javier, people are worried that you see foam in the deep system and that could cause a problem. In your experience, have you had many problems with deep venous thrombosis?
I don't have cases of DVT thrombosis. And I think the first fear of this technique is the massive migration of foam to the deep veins. But I think it's not a problem.
As everybody knows, when we inject foam goes everywhere. So the one other question is, you have a special technique of creating foam. What is that technique of creating foam? You add materials to the sclerosant. What is it?
I basically use two types of sclerotherapy agents, the polidocanol and the lapirium chloride. Now in Argentina, we don't have more the lapirium chloride, and we continue with polydocanol.
Thank you very much. I'm going to turn the floor over to Shoaib, and the floor is yours.
Thank you, Lovell. Just a clarification, I'm not from Italy, I'm from India, but thanks very much. And Javier, lovely presentation. Thank you for this interesting technique. I have a few comments to make here. You know, whenever we use foam in veins, the idea is to have the least diameter of the vein so that the lesser amount of foam that we inject, the vein goes into spasm, and we don't really have this problem of thrombectomy later on. Now, when you use the tourniquet, what you're doing is you're creating large veins, and obviously the amount of foam that you're injecting into the vein is going to be of a larger quantity. And as you showed in some of your slides at follow-up, there are large engorged veins which are there on ultrasound. So that's one issue, that there'll be a larger amount of foam, and it's difficult to aspirate that foam out of the vein once, you know, parts or segments of the vein have gone into spasm. So a lot of foam will remain behind, and this can later on give rise to an inflammatory reaction. That's my concern. The second point is that we have been doing a similar technique like yours for many years now. And what we do is, when we want to basically occlude a truncal vein, I would go to the cranial aspect of the vein and give a little bit of tumescent anesthesia around the vein and close the vein at that point. And at the caudal portion of the vein, maybe above the knee or below the knee, I'll then inject a little bit of foam and massage that all the way cranially. This creates two things. One is that it's a lower volume of foam. The vessel is also smaller, and our incidence of inflammation and possible thrombectomy is almost nil. What would you have to say to that?
Shoaib, those were great comments, and it'd be interesting to hear from Javier about the use of tumescent to compress the vein so that you don't have as much foam that you need. So Javier, please address the questions and statements.
First of all, this technique is very, very old. I can find, but it's a very, very old form. The injection with the tourniquet, you are segmentation. For example, if you want to treat entire saphenous vein, you segment in two portions the saphena for the treatment, and the other is the runoff. I think using a dense foam and the tourniquet, the foam works like a non-Newtonian liquid, and is very important because you can drive in a better way the foam.
How much foam do you use, Javier, to treat a great saphenous vein? How much foam do you use to treat the great saphenous vein?
As you saw in Asunción, the amount is directly proportional to the diameter of vein. For example, in the slide, 40 millimeters vein aneurysm, and the saphenous vein is about 3 centimeters. I think I use 30 millimeters of foam only for the saphenous vein.
13.
30.
30.
30.
30, Tobias.
30. Doctor, you know, is the consensus talk about 10 millimeters. But I have a witness, Dr. Lowell, So how many millimeter I use?
That is correct. Shoaib, any other further?
One more comment, Javier. When we use a tourniquet or any compression device proximally, what happens is that you dilate almost all the veins which are in the caudal section. Even some of the veins which are not refluxing, which are not clinically evident in the patients. And because you now see them significantly dilated after putting the tourniquet, you'll end up forming those veins also. How do you prevent that from happening?
Please, can you repeat, please, doctor?
So when you put a tourniquet, all the veins which are below the tourniquet will become dilated, even those which are not pathologic veins. And because you see them dilated on ultrasound, you will now inject foam into those veins in order to close them. So I think that's something. How do you tackle that particular problem?
So Javier, the question was, if you use a tourniquet, the veins dilate below the tourniquet. And also some of the normal veins will dilate because you are constricting blood flow.
Yes, but the idea is to full the vein with foam using 2 tourniquets.
Okay, I'm going to move on. Tobias?
Yes,
Floor is yours.
thank you, Javier, for sharing your experience with this technique. I have read about that technique, but we have always learned that we should not use tourniquets for doing that. One question I have when I think about that is, if you use a volume of up to 30 milliliters and you stop it, once you open the tourniquet, you will have a big bubble. And so my question is, do you see visual disturbances or anything like that? Or which are the limitations when you would decide not to use that technique? This is one question. The other, I thought about, we have a lot of perforators, and we know that every leg has more than 100 smaller and bigger perforators. And if you constrict above and below the area you will treat with foam, you will definitely have a lot of foam in the perforators. And is it an opportunity to treat incompetent perforators as well? I will understand that in the healthy system, the foam will flow away. You will not constrict, you will not do a tourniquet that way that you will also occlude the deep vein. So I'm sure it will flow, but you will have the foam in the perforator, and that's why my question is this maybe also an opportunity to treat incompetent perforators?
So Tobias, quickly repeat. I think you had more than one question. Would you repeat one question and let Javier answer?
Yes. My first question is, which are the limitations? When would you say, in that case, I would not do that type of treatment?
Doctor, I only use sclerotherapy. For example, the common contraindication of sclerotherapy, only this. For example, a diameter is not the vein diameter is not the contraindication for me. And to Dr. Padaria about amount, we are talking about 0.5 centimeters safena or 30 millimeters safena. I never use the same. I never use the same amount, but if the vein need more amount of foam. I use what I need.
Tobias, further question?
Yes, the other question was, is there also a treatment of the perforator when you administer the foam in the dilated superficial vein? We have incompetent perforators, and we also have perforators who have a physiological function, who should bring the blood from the superficial vein into the deep venous system. And do you harm the perforators, or is it can you treat incompetent perforators?
The idea is use first a very, very dense foam, and the second is the ultrasound guide. I may inject big volumes, but in one injection point, I only inject 2 millimeters. I think it's not a problem what you are talking, doctor.
Are you?
Tobias, let me phrase it in a different fashion. The question, Javier, is that because you have tourniquets, you're creating pressure between the tourniquets, and you may be forcing blood into a perforator, because that's the normal way it drains from
I
superficial.
think, sorry, I think you already has a dilution in blood.
Okay. Emery, the floor is yours. While we're waiting for Emery, there is a question about how long you keep the tourniquets up, in other words, in place, before you release them. And so
For
1 minute,
example,
2 minutes.
for example, if I have to treat a leg, for example, tourniquet on ankle, tourniquet on knee, injection. The ankle tourniquet go to groin and wait about vasospasm.
So in my opinion, when I watched Javier do this, he waited for venous spasm. And once the venous spasm was achieved, the tourniquets were released. As we know, foam travels everywhere, but it wasn't a huge bolus. I expected to see what Shoaib said and maybe Tobias said, this big volume of foam going, but I did not see that because, as you know, using proprietary foam in the US, we don't see a big bolus of foam going into the deep system. So I know that Javier is very comfortable with this. I know that he doesn't use any other treatment other than foam. So I do not see Emre. And any other further questions from or statements from Shoaib and Tobias? Please.
Javier, I saw the pictures of the tourniquets that you had put in your patients, and they seem to be pretty tight. And would you consider using a blood pressure cuff and monitoring the pressure adequately so that you don't compress the deep veins and you only compress the superficial veins, both proximally and distally?
I think it's a more simple a rubber tube or a glove for the very, very thin in my tourniquet. The pressure.
Yeah, but the
And
question is, we're not sure what the pressure actually is. You can't quantify the pressure that you're giving
no,
into the legs.
no, doctor,
So
no.
yeah.
The idea is to tie and not will be discomfortable for the patient.
One last question. Once you use this sausage technique, in your experience, what percentage of patients come back to you on follow-up with significantly dilated thrombosed veins requiring thrombectomy? What's the percentage?
For superficial thrombophlebitis, about 20%. But I look sausage and typical sclerotherapy. The sclerus are small and no several reaction of thrombophlebitis reactions.
If on your follow-up ultrasound, you find a large vein, let us say a great saphenous vein, which is 7 or 8 millimeters in size, in diameter, it is closed, non-compressible, would you now put in a needle and aspirate that thrombus from within that vein?
Yes, I ever or thrombectomy or aspiration of the liquid part of the sclerus.
Tobias, any further?
Yes, would you prefer that technique more for veins inside the saphenous space, or also for veins out of this fascia with very superficial veins? Would you say it is better to find veins who have that internal compression with a fascial space, or can you do that also with every superficial vein with the tributaries and varicosities? From time to time, we have diffuse big varicosities. Is it good also for those? Because my imagination is, if we dilate it, we will have bigger nodes, bigger sclerothrombi to puncture after that.
So your question, Tobias, is simple.
I use
Sorry?
for
Well,
Your question
so
simply.
better to use for truncal veins or for superficial varicosities?
I use for all, doctor. Only change the sclerotherapy agent concentration and the quality of foam.
And one technical question, you mentioned you use several concentrations, and you said up to 3 or more percent. Is there 4% still available in your country? I
In
remember that
Argentina,
4% for polydocanol as well. Or are you then using STS because this has a higher effect?
Tobias, your question is, number one, do you have polydocanol 4% in your country?
doctor, in Argentina, we have polydocanol 0.25 to 8%.
Oh, great. 8%.
Okay. Anyway, I'm going to have to stop this. I wanted to thank everybody. Javier, thank you. Shoaib and Tobias, much thanks for your questions. Next week, Wednesday, July 2nd, 12 p.m., Alexandra Jaworska will be talking about vaginal varicosities, etiology, and how we treat. Thank you for joining, and we'll see you next Wednesday, July 2nd at 12 p.m. at VLU Grand Rounds.
Improve the sausage.